Good morning. Good morning, everyone. So welcome to Samsung Medical Center and 앙코르서울 2024. So today we like to treat the calcified lung lesion with a history of burr entrapment. So I'm Hyeon-Cheol Gwon from Samsung Medical Center, and the second operator is Jumyoung Lee, and the third operator is Uchang Gwon from Gangbuk Samsung Hospital. And Chang-Won Kim is the pros, our fellowship trainees. Okay, so Dr. Gwon, please introduce our case.
Yes. The case is 88-year-old female who was referred from the endocrinology outpatient clinic due to the exertional dyspnea of NYHA class 2 to 3. Her clinical presentation indicated stable angina, and the echocardiography showed finding consistent with the ischemic heart disease with the preserved LV systolic function. Her regional wall motion abnormality was found at apical anterior wall. Her past medical history included hypertension, diabetes, and dyslipidemia. Her chest PA showed nothing of interest. And her EKG showed a non-specific ST change, but no significant emergence findings. And the coronary CT was done, and there was a diffuse stenosis in the proximal to mid LAD with a heavy calcification. So the CAG was done, and RCA was small, and though the diffuse luminal irregularity was found, there was no significant lesion in need of PCI. Next. And on the CAG, consistent with the CT finding, there was a diffuse stenosis up to 70 to 80 in the proximal to mid LAD with the heavy calcification. So the PCI was planned with the elective rotablation, but when the 1.5 millimeter burr was used, the burr became locked. Next. So it had to be removed with the forceful pulling. And fortunately, in the final CAG, there was no sign of acute complication, and here we are.
So I was called by my junior faculty members. The burr was lodged. Previous slide. Slide, please. So the burr was entrapped in the proximal LAD, and he cannot remove it. He pulled it, but it didn't come out. So I joined the intervention, and what I was done was just a strong pulley, stronger pulley. So you can see the guiding catheter is deep engaged during pulling. So this is not the right technique, actually, as you can see. We need to pull out the guiding catheter as far as possible, but at the time, the strong pulley guiding catheter is going inside. Sometimes it makes a dissection. So, as you know, the preferred technique is to use the guide extension and to remove the sheath of the burr, but at the time, just try the strong pulling. It did come out. So this is what this case is for live case. Next slide.
Did you try the low speed when you removed
no.
the
At
low?
the time, the routine speed is 180 RPM.
No. When after trapped of the burr, you removed with forceful pull. Have you ever tried the low speed?
My junior, Dr. Chia, tried the low speed first, but it didn't come out, and tried to pull out, it didn't come out. That's the story. So low speed, burping pedaling, burping start is the first thing you should do to remove the burr out of when the burr is trapped. So you're right. So the issue is that how to avoid the burr entrapment. The two choices, I think, try smaller size of burr or the same size of burr with a higher speed with light packing. This is first issues. Second is when burr is trapped, I'm not sure at this time. So when burr is trapped, the how to retrieve the burr. And thirdly, actually, this is very calcified, diffuse lesion. So doing it 1.75 burr. And I'd like to show the utilization of OCT in calcified lesion. That's all. So all up to you.
Okay, is there any comment from the panels?
Yes, okay. I'm Yoshihumi Kashima from Japan. I have some comment. So, I saw when I saw the previous PCI, so that operated manipulation is looks strongly. So because this is a diffuse region, if a strongly push, of course, easily stacked but in anywhere. So at the first we have two options to prevent bad stack. First, of course, we need high speed. I mean maximum speed, 230 around.
Yeah.
Second, of course, we need to get good, great acute gain for proximal, then step next part, so graduated and rotablation. So we need two options with gently burr manipulation.
So which one do you prefer? The smaller burr and the high speed?
Yes, of course, and the straight part 1.25 is easily made and easily rotablation. However, this region has bending part and at the distal part, so 1.25 easily stuck at that portion. So I strongly recommend 1.5 with high speed setting and gentle burr motion.
Okay. So I really agree with you, and I prepared the 1.5 first. So if unfortunately the burr is enlarged, we have a chance to show you how to retrieve the burr. That's what I don't like, actually. And do you think we need a 1.5 burr? Maybe I can show you the OCT, and I will probably to make you make a decision easier. Dr. Lee? We actually, during the preparation, we already performed the OCT examination. The OCT on the screen, please. OCT on the screen, please. OCT? So the actually routine procedure in our cancer center is just to assess the calcification by angiography. If you find parallel calcification in each side of vessel, we think this is the indication of rotablation. After that, you use OCT. But in this case, 처음부터 다시. In this case, we try OCT before rotablation. Fortunately, it passed. That's a lot of resistance, but we succeeded.
Actually, doing the OCT pullback was not so difficult, and this OCT was done from the video LAD segment just above the second diagonal branch. And as you can see, the huge calcified plaque, mainly the superficial calcification at 360 degrees. And we are approaching the point that the previous burr was lodged at this segment, just below the first big diagonal branch, and huge calcification. Yeah, this one is the diagonal branch and the proximal reference segment. And could you stop the OCT and show us the calcium thickness? So we measured the maximal calcium thickness at this segment, and it is around 100 micrometer. So based on the OCT scoring system, the more than 180 degree of the calcification, thickness more than the 500 micrometer, and length more than 5 millimeters. So OCT score is around 4. So we are expecting suboptimal stent expansion without advanced lesion preparation.
So he said 100, but actually 1,000, right?
Oh, 1,000, yeah.
So more than 500 micrometer it got the 1 point for the OCT examination for the indication of rotablation. Can you show the point when the proximal LED, when the burr was latched, where the burr was latched, proximal, this
that
diagonal,
point,
yeah, and a little bit distally. A little bit distally, please. Yeah, your huge calcification, circling calcium. So it's the kind of
looks like a very irregular surface of the calcified lesion. Maybe this is the cause of the entrapment. Maybe I think we need to do the polishing by the rotation. How do you think? So we can see a very irregular surface of the calcified lesion. Maybe this is the cause of the trap or the rotor. So how do you think?
Right.
So Dr. Gwon, Giulio Gugliumi, I'm watching to this segment and the area was about 2.2 and the calcium a little bit distributed around the circumference and not very close to the inner lumen. So I'm in favor to go back with a 1.5 high speed having this data. That's my point.
Yeah.
Okay, consensus is 1.5.
May I proceed?
You may need a bigger 1.75 later.
Later, really. So it's surprising that usually we don't see the vessel wall by the OCT, but in this case, it's a small vessel. The vessel size is maximally 3.0, so we can see the electron lamina, EM, so we can measure the vessel size of 3.0. Can I show the IVUS actually? So during the waiting time, we did the IVUS too. So IVUS again. IVUS does more clearly show us the vessel wall, but it was possible with OCT. IVUS on the screen, please. IVUS. Okay. Yes, pullback speed 1.1 millimeter per second. Yes, the distally calcification in each side. Proximally not calcified here. Okay, from here is the lesion, distally. And proximally, this is the encircling calcium, irregular surface. But we cannot see the calcium thickness. But the vessel size around 3 still. Around here is the point where the burr was stuck. And yes, we calcified encircling. This is big diagonal, proximal to the lesion. And proximally, we can see a vessel size is more than 4. But in the lesion, maybe there is a negative remodeling, I don't know, but the vessel size is so large. So I'm not sure we need 1.75. After rotablation, we can check it again. So we start rotablation. Okay, 이거 좀 잡아봐요. 오래 기다렸어요. 다 말라가지고.
At some point,
the wire,
the thickness of calcium is very thick.
Yeah.
Thus, I suggest there is a
그러죠.
little possibility to use bigger burr.
이게 나오는 거 보죠?
Or you can use a single 1.5 burr with 2 different speed of rotation. First with high speed, later a low speed to expect a little bit orbital motion to debulk more with the same 1.5 millimeter burr.
나왔습니다. 이제 나왔습니다.
Okay.
선생님.
On.
테스트 하고 갈까요?
Test on. Yeah.
다이나 먼저 할게요.
Dynaglide. Okay, stop.
네. 로타.
Yeah. Speed 22, 120. What's the maximum? 230. 222, 23, 24. Yeah, stop. Yeah, 224 is maximum in rotablation. Okay. Well, dynaglide.
예, 잠시만요.
Dynaglide.
네.
Okay.
이거 잡아주고.
야, stop. Dynaglide. Okay. Dynaglide.
In my lab, we always introduce one ampule of
조금 와이어 좀
atropine
빼야
just
되는데.
before
할 때 조금 빼죠.
rotablation to prevent
좀 빼죠.
bradycardia or
Okay.
AV block.
다시 원할게요.
네, Dynaglide.
가지고.
Okay.
Dr. Gwon,
Yeah.
could you try the coaxial alignment toward the guiding catheter? Sometimes it's very important to avoid.
Yeah. Actually,
Different,
this is a line, I think. Test.
예.
A line of guiding catheter. Test.
Don't you use prophylactic medication to prevent bradycardia after rotablation or slow
와이어 빠졌다.
flow or no reflow?
Actually, my technique is just to start the rotablation in the platform for 3 seconds. Then we check the bradycardia, and it is okay. I can proceed. But if there is bradycardia, we use the aminophylline, the half of ampoule, 125 milligram. 좀 10cc 좀 섞어놔주세요. 0.5 aminophylline. Yeah, but I think you prefer the atropine intracoronary injection, right?
Yeah. Just coronary injection, 1 ampule of atropine. Just try
Yeah.
today.
So we'll try our way first. Then it fails, I'll try your way. It's fair, right? Okay? Okay, let me. Yeah.
넣어볼게요.
Yeah. Just hit the platform, just ablate. Yeah, 3 seconds. Can you see the vital sign?
No,
Vital sign on the screen?
no screen. Okay, we can see.
Yeah, there is actually there is some fluctuation of the blood pressure actually. So I'll give the aminophylline first. 10cc 섞어서 1분간 injection. So there are several protocols for aminophylline. Initially, the 1 ampoule injection for 10 minutes. If on the published, and I prefer the 0.5 half ampoule of the aminophylline, 125 mixed with the 10 cc, and the slowly injection over 1 minute. It's faster, and I think, yeah, blood pressure got increased. Not yet injected.
You have 5
So,
minutes before turning to the Severance Hospital.
Okay, I'll proceed. Yeah, light touch, high speed. Currently 210 pace. Very light touch. Okay. Actually, my junior faculty tried just one round of ablation and hit the forward stopped. I'm not sure he was pushed hard at the first round, but I don't think so. That you can see the blood pressure is going a little bit down and up. Okay. I like to, as gentle as possible. Yeah, proceed it. Yeah, you can see the progression of the burr, right? Okay.
I think in this part is the starting point because in the rotablation don't like in the acute bending. But
Bending, right?
yes, rotablation. Especially in the acute bending in the short range part. So
Right,
I strongly recommend in the low speed rotablation only here. Then you can
Low
get
speed.
in the much more extra acute gain. Then rotablation is prevented and the stacked bar.
Yeah, but blood pressure is lower.
하이드레이션 좀 해주세요.
하이드레이션 좀 해주세요. 노리플로? 테스트 해봐요. 테스트?
괜찮습니다.
There is no notiflow. But the low speed is there is higher chance of burr stocking with the low speed, and I stay on the higher speed. But the pressure got low.
레고 패드 걸어.
Dr. Gwon, hi, it's Michael Lee.
Yeah.
We used to always, good to see you. We used to always have hypotension when we used to do this. So one thing that we've switched is not using the Rotaglide mixture, but rather we just get a bag of saline and put 10,000 units of heparin in because it doesn't have any vasodilators inside the Roto mix. So that's what we've done. We've noticed a lot less hypotension during atherectomy. That's just a consideration.
What medication?
Just one
Inside of a mixture?
1 liter of saline and just put
Saline?
10,000 units of heparin in and doesn't have any vasodilators inside.
Yeah. Actually, our protocol is Nicrandil was next year. So it's one of the mechanism of hypertension. Yeah, I agree with you. Yeah.
Another thought is in the US, we hardly ever use rotational atherectomy. We either use shockwave or we use orbital atherectomy, and we almost never see burr entrapment or crown entrapment because it's more elliptical process.
Yeah, hopefully next year IVL is available. 가슴 아프세요? 가슴 아파요? 아니요? No chest pain yet. So I try again. Now the aminoxylin is working, I think. Yeah.
Okay, you already passed.
Yeah. Okay. We passed the thickest point, but there's another bending at the angle of a LED, so I'll be very careful and the slow progression. Blood pressure is fluctuating.
Why
So
don't you
it's
try,
coming
why
up.
don't you try atropine intracoronary? Just simple. And see.
The current heart rate, really? Okay, atropine, half ampoule injection.
1 ampule.
You can see it.
1
Yeah,
ampule.
1 ampoule.
Yes.
Really?
Actually,
One ampoule.
half
one
ampoule
ampoule
is-
is 0.5 milligram.
Half
Okay, 1
ampoule is
ampoule.
not sufficient to
Intracoronary.
block.
Okay, I have never done that, but I'll do it for you.
Okay, 받아요.
Dr. Gwon, prior to the procedure, did you get an LV EDP to assess his volume status?
No, not routinely. But we give the volume now. We are giving a volume now. So this is half one. Okay, I'll give it. 왜 10cc 시리즈에 줬을까?
그럼 채우겠습니다.
Flushing.
Question? Okay, I gave it.
I'm not sure if perhaps there's different pharmacotherapies, but at least what I use is phenylephrine at 100 mics. It's very effective for increasing blood pressure acutely without the increase in chronotropy. So it's one of my favorite pharmacotherapy agents in the cath lab without causing
Problem is that
tachycardia.
I'm worrying about the tachycardia by the atropine.
Right,
That's
that's
why
why
I don't use
phenyl-
Heart
atropine.
rate is very
Currently, heart
important.
rate is 144.
Heart rate is very important to increase perfusion.
But too much. There
That's-
will be a ischemia, just like a treadmill test.
This finding suggests the patient was under vagal tone.
No.
This is neutral status.
Too low vagal
Just
tone.
block vagal tone
Yeah.
and native sympathetic activity.
Yeah.
Just hurry up
I like to hear from,
ablation.
Yeah. Anyway, I proceed. Heart rate is
There is
too
no
fast. That's one
fear
of the
of
limitations
sinus
of atropine.
bradycardia evoke in this condition. Just hurry up the ablation.
Now patient is complaining of chest pain because heart rate is fast.
Because
very fast.
tachycardia may exert discomfort for the patient. Don't worry about
Right.
it.
Yeah.
Just hurry up the ablation procedure.
I'm worrying about the chest discomfort of patient. I'm very empathic. Yeah, blood pressure is okay. Yeah, okay.
So such kind of blocking of vagal tone is very important to expedite ablation procedure.
What do you think, Dr. Lee? Do you like a tachycardia here?
I'm not sure that those tachycardia was problem of aminophilin or atropine, but I also prefer intraocular atropine and as well as aminophilin.
So,
Yes, please
anyway,
stop aminophilin.
Yeah, aminophilin was just injected
Just gone?
once.
Okay.
It's gone. And actually, do you prefer low speed? I do the
low speed. Polishing.
Just a high speed first.
About 1500? No, 150.
Still 200.
150.
And I'll try the low speed.
Yeah.
The 140.
140. Okay.
Oh, stop. Yeah. Okay. Yeah. 140.
거꾸로 돌리고 그랬죠.
됐죠? 딱 됐죠? 가슴 아프세요? 가슴 아프냐고 물어보 손? 조금 더 위로? Yeah. Patient complain chest pain, but I don't like it actually. So low speed ablation. Actually, in the vitro test, I found that low-speed ablation increases diameter on the proximal part because there is no vibration in the middle and distal part. On the proximal part is more dilated, I think. So, okay, then remove burr. Dynaglide.
Yes.
Okay.
But did you already polishing process with low speed?
Yeah.
Okay.
Low speed, right. High speed once, low speed once.
You have 50 minutes.
엔저 준비? 응?
이거 다시 퍼프할게요.
퍼프하고. Yeah. Wait a second.
한번 보여주세요. 네, 할게요. 네, 됐습니다. 네.
준비? 네. We did the ballooning. And, 준비? Sure. Okay. Okay, we did OCT and balloon and OCT. Yeah. Okay, first OCT 좀 보여주세요. Firstly, after rotablation, angiography 먼저. 아까 놀이 flow, angiography 좀 보여주세요. angiography. Okay, 그전 거 전. Okay. So we got a little bit slow flow after the rotablation. I'm not sure this is because of the high speed or low speed. Higher speed increases plate aggravability. Low speed increases the size of debris. Maybe both are working on it. And so we gave the Nicrandyl injection twice. Then we next.
Slow flow.
OCT. Yeah, then we a little bit improvement of nodal flow. Now slow flow is gone anyway. We did OCT at the time just after rotablation. But OCT on the screen, please. OCT on the screen. Okay, play. Dr. Lee. Yeah, just after the rotablation, before ballooning.
Yeah, you are seeing the OCT pullback just after the rotablation from medial lady. Dr. G, can you tell us any interesting finding from this OCT pullback?
Actually, I expected some crack and the calcium, and it really found, right?
I don't think so.
I have seen a lot of pictures of crack after the rotablation, actually, it doesn't happen a lot. Anyway, the Rotablation is 1.5, and you cannot see very clear difference before and after. It happens a lot, right?
And we measure the calcium thickness at the point that the previous burr was lodged. At this point, can you see the maximum calcium thickness was previously over 1,000 micrometer, but it is around 780 micrometer. So after this, we did balloon angioplasty.
Yeah, we decreased 0.3 millimeter diameter of the calcium. This, I think, hopefully it can reduce the risk of underexpansion. Hopefully, we have some micro dissection inside the calcium. So next. So we did the balloon, 2.5 by 30 millimeter, and you can see some under-expansion of the balloon. Angio on the screen.
Big dissections that you can see around the calcium.
Right,
so that is plus cracks. Here you can see at 6, at 11. So there was a big difference in terms of impact on calcification.
Okay, so we did 8 atmosphere distally, approximately 14 atmosphere, and at that point of where the ball latched, we can see the under-expansion of the balloon. So we applied next. So 2.75 NC balloon up to 18 atmosphere. So I'm afraid of using a higher pressure. There is some risk of perforation. That is the worst scenario, actually. So, and after go down, and we did OCT again. We see big dissection, as you mentioned, in the medial AD. And I wonder if we can see in the OCT. OCT on the screen?
Is running.
Yeah, you can see the OCT pullback just after the balloon angioplasty. And as Dr. G just said, there were huge dissection, but we can also see the crack at the calcification and huge dissection around the calcium.
It's not
but
only
I think
deep,
the luminal expansion, it looks great.
You can see also in the contralateral vessel wall some cracks. You can see at a 4, at 3. So that is good because it's distributed around the entire circumference. And Dr. Gwon, you measured the EL more than 3.0 in IVUS. It was about 3.2, 3.25. So I think that if you decided to go by stent at this point, the lesion preparation seems to be enough for the weight.
Thank you. So next, I'm very happy to hear that. And actually, in the angiography, the medial AD, as the distal tip of the OCT, there's some residual stenosis. This is because of dissection and hematoma, I think. So what do you think of the size of the stent here? 2.5, 3.0 is definitely large. And I like to start with the 2.5 and see what happened here. And we try another stent proximally.
Maybe we can try could you measure the distal reference segment EM diameter on this OCT? At that point, or more proximally. Let's apply the Illumine-4 algorithm of this side. Those EM diameter is 2.7, around 2.7 or 6. So maybe at distal LAD for the 2.5 millimeter stent, and the proximal LAD around 3.0 millimeter stent.
So the diameter is?
The EM diameter is around 2.6 or 2.6? Yeah.
I'll try 2.5.
Yeah, 2.5.
And we can dilate further anytime, but we have, it's a calcified lesion. I like to apply the higher pressure, start to low. So 38, 2.5 giant stent.
Can you measure the length of the lesion? Can you show that at this 30?
Yeah, please measure the length of the lesion.
정만쌤, 우리 proximal reference를 proximal LAD로 more proximally.
아래쪽 다이고널에서 위에 다이고널까지. 네? Stent? Anyway, we need two stents, I think. So we start with the 2.5, covering the loaded second diagonal and septal. There is possibly if there is hematoma, maybe we can migrate the hematoma distally. So I like to start very slow inflation, collecting the distally.
My personal practice is if you need multiple stent LAD from LAD ostium or distal LAD, I always use the shortest length of distal small stent. 2.5, 38. Mid LAD is covered by 2.5. It is insufficient. Thus, I always, in this case, I just start putting bigger stent from the proximal. Then I'd like to shorten as possible the distal stent with small caliber. Thus, as we can see, 2.5 stent cover even mid LAD. That is insufficient.
So, Dr. Kim, you are right about the sky point has a range of expansion that anyway allowed to correct this 2.5 in a bigger size.
I'm concerned about metal to vessel ratio. If the small stent is fully inflated, I think the metal coverage on the vessel may be lessened.
16? I'm afraid of perforation. Deflation? Okay, I just apply the 10 distally and pull back and 14. Test? With the larger vessel, actually, I don't hesitate to 18, 24. It's not a problem. That's a small vessel. You have to very careful test. There is some dissection distal proximally. Angel?
Yeah.
Sure. Okay, this side is okay. We didn't migrate hematoma distally, and branch is okay. We can go up to the first diagonal. Yeah. So then. Let me check again. So I missed it. So here is the simulation. Test, Angel, test. Hey. So stent 83, 28. 28.
Dr. Wong, if you watch to the OCT, the dissection is also back to the takeoff of the diagonal. And you need to take into consideration the length for a pot. Because there is a big difference between before and after.
But the entry of dissection is inside of calcium, so we don't need all of the dissection or hematoma. So entry occlusion is enough. Maybe we need. Do you like to insert the longer stent? If you like, I can do that. 32 or 33.
Oh, that's too long.
Too long.
Yes.
Yeah, my technical operator disagree with you.
Based on the OCT, 28 will be.
Okay, 28, 3.0.
Where is proximal landing zone?
Protective wire into the oil.
Nope.
Where is the proximal landing point?
Just above the second diagonal, first diagonal. There is some hint of hematoma at the entry of diagonal. So if I put the stent there, there is a risk of a compromise of diagonal. So my third operator, Dr. Gwon, suggested we need to protect the diagonal branch with another wire. What do you think?
I agree.
Agree?
Yeah.
Let me check. Okay.
Can you see the evidence of hematoma around a bifurcation?
You can see a small eyebrow at the top of the ostium of the first diagonal. Can you see that? Yeah, if there is a dissection, always this kind of long lesion, always there is some hematoma around there. So suddenly we have a occluded side branch or something. So So I do a very slow inflation and low pressure first. Then too long. 프락시멀 가야겠는데? 28이죠, 이게? 여기까지? Okay? Yeah, 8. It's longer than I thought. 10. Okay, I'll stop here, deflate, and check the diagonal branch for the possible occlusion. Angel? Sure? Okay, it's okay, right? Still, we have some eyebrow sun at the ostium, upper part of diagonal, but it's okay. So I'll go further from the distal. Okay, down there. Inflate, 14.
Dr. Gwon's inflation time is also 5
Deflation?
seconds.
Yeah.
That's problem. Yeah.
Just 1 second, sorry. I didn't. So maybe we need some additional. Actually, I'm not sure. Proximal, what the diameter of a proximal lumen?
You can see the proximal
More
reference
than 3.
segment, maximal lumen is more than 3.
Vessel is more than 3, but
No,
I'm
no,
talking about lumen.
lumen diameter is
2.85.
3.16.
Yeah, here. Okay,
Yeah.
okay. 3 point.
Please increase up to the RBP.
어디 사이즈 나오지, 이거? 저거요? Maximum 3.16. So
325인치.
but we don't need we need a NC balloon, the larger balloon.
Sure. Yeah.
It's
Really?
calcified
Yeah.
lesion.
We don't worry about dissection. Okay. So 3.5.
When we see
12
the
millimeter NC
angio,
balloon.
there is a
Yeah.
definite underexpansion of mid-LAD compared with distal LAD size.
Yeah.
Don't you agree?
Yeah, I think.
So
yeah.
OCT
Yeah. Just the
is
distal
helpful,
septal
but
branch.
it is not absolute
NC
indication.
balloon 짱부터 할까?
Just see the angio.
네, NC 3.0, 3.0, NC, 275 NC?
아까 나왔던 거. 네.
Oh, yeah. 2.75 NC balloon, try first for the mid LED.
Okay, Dr. Gwon, you have about 1 or 2 minutes. We have to move to the Dr. Bum Gi-hong, Severance Hospital.
So then I'll do the NC balloon mid LED and try 20구나. 테스트. 너무 긴데? 너무 길어.
이제부터 올라오셔야 돼요.
Inflation.
How is the size of
18?
NC balloon? 30?
2.75, 20 millimeter NC balloon.
Okay.
20.
From the
Deflation.
why don't you use NC balloon from the distal or the standard segment? 275. No possibility of rupture.
Really? Okay, I
In my
believe in you.
experience.
Test.
It's already ablated.
I
Plaque
like
is
to finish
ruptured.
without complication. Inflation?
Calcified
18?
rupture. There is no
18?
chance.
Oh, very large. Still under deflation, still under expansion in the medial AD, but recently our second generation DS is working very good. Still under expansion is a problem, but I will check OCT.
Well, why don't you do the larger balloon for the proximal?
Yeah, we have out of time.
Oh, okay. Yeah.
I'd like to show the OCT after the stenting.
Angio would be enough.
Really?
No OCT.
Yeah, we can see the angio and OCT together.
Okay.
No, right here. Okay. 오케이. 센티미터 조금 안 닿았는데 사실 또
조금 더 내려가셔도 돼요, 선생님. 어차피
맞죠. 여기까지 나오지. Sorry.
Okay.
오케이.
퍼프 하겠습니다. 네. 플러싱 하고요.
네.
네. 준비됐어요.
오케이.
네.
No.
잠깐만요.
네. 오케이.
네.
네. 오케이. Yeah, still we can see some underexpansion in the medial AD, but possibly it's because of eccentricity of the calcium, and we like to definitely we need the imaging there. Sometimes we can see underexpansion in this view, and the epicranial we have enlarged vessel. So when the calcium is eccentric, I'm not sure at this time. So OCT, can you explain it?
Yeah. Could you pause the OCT and click the yellow box?
Yellow box.
Let's see the underexpanded segment. Pause, and click the yellow box.
30mm. 그 밑에?
Yeah, actually the MLA is just stent distal. So could you move the reference segment? Okay, yeah. And play again. Yeah, when we see the lumen profiles in the upper segment, we can see homogeneously well expanded stented segment.
좀 봐줘요. 괜찮아?
Okay, well opposed. Let's see the yellow box only.
Yeah,
There.
pause and
Stop.
click the yellow box, please. Yeah.
Stop. 30mm에.
여기.
30mm. Okay. Yeah.
Looks good. Acceptable. Acceptable.
The malposition is
approximate
quite frequently seen after the calcified lesion because of irregularity of the calcium, as you can see.
루멘 프로파일 끄고, 예, 여기 빨간색 뭐 있는지 봅시다. 빨간색만.
So it's very intriguing because we prepare the lesion and the surface of the lumen is very regular. And so we expect that to have some type of malposition. The proximal part seems to have a larger part of malposition that we needed to fix.
Right, yeah, definitely we need a larger balloon for the proximal, for the malposition.
Just 5 seconds inflation. That results in such kind of malposition. If you inflate about 40 seconds, even with stent balloon, all well opposed. Thus, inflation time of stent balloon is very important. 5 seconds definitely insufficient. Please do 40 seconds. If patient not tolerable, 20 seconds, 20 seconds, 20 seconds.
Yeah, I agree with you. In the vitro test actually show that the longer duration of inflation have a large expansion. As even in the bifurcation, we found the same findings. So,
okay, Dr. Kwon, time is out. It's a really wonderful educational case, as usual. Thank you very much for your wonderful live demonstration. We have to move to the Bumgi home.
Yeah.
Okay, thank you.
See you next time.